I have the pleasure to introduce Dr. Sanjay Chaudhary. He's the chairman and managing director of the I7 group of hospitals, and he hails from Delhi. And he'll be talking on long-term outcomes with ICL. And ladies and gentlemen, let me share with you, I think he's one of the highest volume ICL users in India. So let's listen from the master himself. All to you, Dr. Sanjay.
Thank you, Dr. Sonu, for those kind words. And I have been asked by Sonu to talk about long-term outcomes with ICL. Now, we have had experience with ICL for now almost about 16, 17 years. We have done a fair good volume, about 7,000 plus ICLs. And we have seen the ups and downs of short-term and long-term. So what I'm presenting to you is now what we have seen in practical life, the long-term outcomes of ICL. So first is ICL crystalline lens touch. Now, we have discussed that this is the vault which should be about the thickness of the cornea, which is about 500 plus minus 200. That is an ideal vault. And this was the previous version of the ICL, which is the V4 model, not the V4C now. The V4C is with the central hole. This model was without the central hole. And this is the one which we have experience of about 15, 16 years. And if you see here on the left side, the vault is minimal and there's a touch here between the ICL and the crystalline lens. We dilated the pupil. You can see the whole contour of the ICL. The vault is negligible, say about 40, 50 microns here, and the touch is in this area. So at that time, which is about 15 years back or 13 years back, we were wondering what we should do. We asked everybody, should we change it to a larger size? Should we wait and watch? The patient was having very good vision. The patient had a number of about 20. And we just didn't want to change the lens because the patient was so happy. So we said, okay, let's wait and watch. So we waited. We asked him to come in every year. At the 5th year, we noticed this little spot here. And on a slit lamp, this is the corneal, this is the lenticular opacity, which is anterior subcapsular lens opacification. In 10 years, the opacity spread out. The cataract was sufficient. It had entered the central area, and we had to do a cataract surgery. Now, we also had situations where there was no crystalline lens ICL touch, but the vault was shallow, and as we classically know, if there is no central hole, there tends to be aquastasis. And if there is aquastasis, you don't get the sufficient nutrition that the crystalline lens requires, and then the cataract starts creeping in. So this is a case where the vault is okay, no hole ICL, and you see there a cataract developing in the center. This is on a slit lamp. This is on a retroillumination. So the statistics which we have seen in our case series with the V4 model. The V4 model is, again I repeat, without the central hole. The incidence of cataract in this series was 0.4%. That means 4 in 1,000, which is again low. The usual period of cataract was 10 to 14 years. And now we are getting some cases every month, the cases which were done 10 years, 14 years back, who are showing cataract, and everything was fine for the last 10, 12 years. The new model V4C, which has been there from, I think, 2009-10, in this series, sorry, 2014, 13-14. So in this series, there's hardly any cataract, hardly any. So this is with a central hole. And we have published, and there are other people who have published, that with this series of V4C, some have seen 0 cataract in 5 years follow-up. Now, this is one of the cases where the patient came with a V4 model. You can see there is no hole here. You can see that there is a PI here, which we had to do in those V4 models, and there's a cataract. And I'll just take you through how we managed it. The management is simple. It's nothing very great, but just to give you the concept, we had to use a toric lens. Why toric? Because the patient had a very high myopia, and the IOL power was -5. So you prolapse the haptics over the iris, and what happened? So now we are, I just wanted to show you something interesting, just a minute. Yeah. So you prolapse the haptics over the iris, visco over and under the lens. You're not too much worried about the crystalline lens now. With the manipulator and a good lens holding forceps, you can hold the lens in a vertical direction, vertical not horizontally, and just simply pull it out. Now, I use an interior chamber maintainer in any high myope which is asking for a lens of power 9 or less. Then this was asking for a power of -5, that higher myopia. And see this, the lens was soft, and what I did was just phaco aspiration. The CD power is 0. It just came out spontaneously. And now we had to specially customize the lens of -5 with toric, and I approached the care people. They made this lens for us, and this is a smart toric. That means it is placed at 0-180, and it automatically corrects an axis, which is I think about 80 in this case. So this is a plate haptic. A plate haptic has a better grip in the bag than the loop haptics. A little more difficult to insert, but it has to be placed at 0-180. Okay, now high vault. We know very high vault, the lens has to be removed and a one size lower has to be placed. If it is threatening a secondary rise of IOP, the angles are very narrow. But don't rush into it. Why not? Because it is known that vaults tend to decrease over time. Because when there's a high vault, the ICL is tight in the sulcus. And when it is tight in the sulcus, it is pushing on the ciliary body and making a dent there. And as it spreads out, the vault starts coming down. So this patient had a vault on first post-op day was 1583. At 1 month, it was 1400 something, down by 100. At 8 months, it was down by another 100, 1300 and something. And at 1 year, it was down by another 100, at 1200, which is comfortable. So don't rush into explanting and wait and observe. If you're not having any problems and the vault is just not too high, then you could really wait and see how it works. Now here's a unique complication. Pigment storm. Now, what is pigment storm? I'll show you the video first. This was at 1 year post-op. And look at the amount of pigment that is coming out from the pupillary area. It's like a storm. I was just surprised, what is this? We have had 3 cases of pigment storm so far. Now, this is again probably because the iris pigment layer is rubbing on the ICL, and that continuous rubbing is making it loose and it could come out. Or it could be an iris cyst which ruptures and it come out. We don't know. We didn't have a UBM. But that is the supposition. We sent it to the JCRS. They have accepted a publication. It will be out for publishing as a case report very soon. Thank you so much.